Uh, the chairperson said it's a new entity, the anesthesia for fetal surgeries or fetal surgeries. I would love to beg to differ, because the first ever fetal surgery was conducted as long back as 1981, August 10 to be precise. And it's an old entity, but unfortunately it hasn't taken off. A lot of issues connected with the conduct of fetal surgeries. As we go along, hopefully for the next 20 minutes, we will know a little more about this. The charm of fetal surgery is the possibility of interrupting the in utero progression of an otherwise untreatable condition. And father of fetal surgery is Sir A.W. Liley. In the year of 1965, he did intrauterine transfusion for hydrops due to RH incompatibility, but it was never recorded as the first ever fetal surgeries done. The credit goes to Dr. Michael Harrison in 1981, who performed the surgery on Michael Skinner, who was yet to be born. It was the first open fetal surgery for obstructive uropathy. And incidentally, Michael Skinner became Michael because the mother was so grateful to the doctor who treated and named him after Michael Harrison. What are the indications for fetal surgery? The fetal surgery is indicated in conditions which interfere with the normal development of the fetus, which when corrected will allow normal development of the fetus further. It is expected that the indication for fetal therapy would expand. Hopefully it would expand. And talking about the epidemiology, the largest series published till today was 52 cases between years 1993 and 2003, which came from University of California, San Francisco, and Children's Hospital, Philadelphia, reported about 42 cases between 1996 and 2002. And those cases, majority were exit surgeries. We'll see what are exit surgeries as we go by. Here and there have been sporadic reporting of single exit surgeries, and exit surgeries are the most commonly performed surgeries. We'll see why later. Contraindications for fetal surgeries are, anyway, there is no hope. There is no hope for the fetal survival, severe affliction, other associated life-threatening abnormalities, chromosomal or genetic conditions, and if you want to add to that, the mother's hemodynamic status or general condition. The problems of preterm labor and premature rupture of membranes associated with open surgery have led to the development of minimal access surgical techniques, and we all thought, or everyone thought, that the minimal access surgical techniques would take off. Even that hasn't seen the light of the day yet. It is not routinely done. It's only carried out in a limited number of specialist tertiary centers. I don't know how many of us would ever see a fetal surgery being done. How many of you have been associated with this? Anybody? No. What are the challenges to the anesthesiologist? The challenges could be those related to any anesthetic in a pregnant woman. We all know what are the implications of anesthesia when a pregnant woman presents to us. The techniques used to prevent preterm labor, maintenance of maternal homeostasis in the face of tocolytic techniques, where you have to make sure that the uterus is maximally relaxed, and meanwhile you should maintain the hemodynamics in the mother so that the uteroplacental circulation doesn't get affected. It's a Herculean task, mind you. Maintenance of fetal homeostasis, even that gets tougher, because the fetal mid-gestation fetal blood volume would be anywhere between 50 to 60 ml, and if you attempt surgeries on such a fetus in utero, obviously the loss would be, in percentage wise, would be a huge loss. Therefore, it's very difficult to maintain the homeostasis. The provision of fetal analgesia during surgery, it's an issue which I will discuss down the line. We have to take care of the fetal analgesia and anesthesia, even in utero. and the distance the mother may need to travel from home because, as I said, it is not practiced in most of the centers, therefore she has to travel a lot. It's again a stress on the person and the family. Interestingly, the fetal surgical techniques are based on years of animal and clinical research. In contrast, anesthesia for fetal surgery is based on clinical experience, case reports, and translation of responses to anesthetics in pregnant sheep. We have never had the opportunity to have an advantage as the surgeons have, who could do animal and clinical research, and we could not. The anesthesiologist as such, it's a major teamwork, and anesthesiologist is a part of the teamwork because there has to be communication between the anesthesiologist and the other parties involved in this fetal surgery, including the guys who practice fetal medicine, the obstetrician, and pediatric surgeon if he is involved. Everyone has to be included in the teamwork, and it has to start much before the patient is prepared for the surgery. What are the surgical techniques? Minimally invasive. You have fetal endoscopic surgeries, FIT-endo. Fetal image guided surgery. You have exits. Exit is, as I said, the most commonly practiced surgery, ex utero intrapartum treatment procedures. And mid-gestation open procedures, they are not so frequently practiced anymore. We'll talk a little bit about the subject must be as new to me as to you people, and we'll just go through what are the surgical techniques which are used. Fetal image guided surgery is ultrasound image guided procedure. There's a needle or a trocar cannula shunt introduced through this. This is supposed to be, the FIGS is supposed to be the least invasive. There is least risk of amniotic fluid leak and least risk of preterm labor. What are the procedures done with FIGS? Is diagnostic procedures are listed out there, and therapeutic could be radiofrequency ablation of anomalous twins, cord cauterization, vesicular pleural shunts, and balloon dilatation of aortic stenosis if the fetus has. FIT-endo is fetoscopic. You have fetoscopic access to the fetus, and real-time visualization of the fetus is done as shown in the graphics down there. And the fetal visualization is a combination of endoscopic and sonographic views on two different screens, and you can also have a laser tubing or shunt passed all along the smaller gauged trocars. And this is less invasive. There's less risk of amniotic fluid leak and less risk of preterm labor compared to open surgeries. The FIT-endo involves the surgeries for balloon occlusion of trachea if the patient has a CDH, and laser coagulation of the vessels for twin-to-twin transfusion syndromes, cord ligation in cases of acardiac twins, and amniotic glands division. They are the commonly used ones. The FIT-endo basically is considered when fetal demise or severe morbidity is imminent or traditional therapeutic measures like amnioreduction have failed. We'll talk about the open surgery because a little more in detail, because anesthesia for FIT-endo or FIGS is not so severely it doesn't severely affect our anesthesia practice because of the advantages which I spoke earlier. But open surgeries are the ones which put us in real quandary because of maximal uterine relaxations, and maintenance of hemodynamic becomes a huge task. It's also termed as mid-gestation hysterotomies, and it is done during the 18 to 26 weeks of gestation. And you have to take into consideration all the physiologic changes of pregnancy which start appearing as early as the conception day. You please do a thorough PAE on your patient who presents to you, the mother, including the airway status. I need not stress upon the importance of airway management in difficulty in managing the airway in any pregnant woman who presents to us. Please take into consideration acid aspiration prophylaxis as well as to avoid the supine hypotension syndrome when the patient comes onto the table. Hydration of the mother is of utmost importance when you consider anesthetizing these patients. How do you keep yourself ready is warm the OR to 80 degree Fahrenheit, keep type-specific packed cells for the mother and O-negative packed cells for the fetus. You need 2 pulse oximeters, one for the mother and one for the fetus as and when the fetus's arm is delivered out. Arterial pressure transducer is mandatory because once the patient is induced, the mother is induced, you have to take an arterial line in and you have to monitor arterial blood pressures, intra-arterial blood pressures. Drugs for the fetus, epinephrine, you have to dilute and keep them 10 mics, and atropine 20 mics, vecuronium 0.2 milligrams and per kilo, all are per kilo, and fentanyl 10 to 20 mics per kilo. Indomethacin suppository has to be inserted even before you induce the patient. It is for post-operative tocolysis. And it is always preferable to put a lumbar epidural, which will take care of the patient comfort after the procedure. And also, you need to activate the lumbar epidural so that you can come down on the inhalational anesthetics towards the end of the procedure. General anesthesia is preferred. Obviously, you can't provide anesthesia only with the regional techniques. To provide the maximum uterine relaxation with high concentration of potent volatile agents, you need as high as 2 to 3 MAC of inhalational agents from the beginning to have maximum uterine relaxation. Mother is anesthetized as you anesthetize any pregnant women, and the uterus is opened maybe preferably the transverse incision, but if the placenta comes in the way, you can also go in for the vertical incisions, and a special stapling device to prevent bleeding and amniotic fluid leak. Intraoperative sonography has to be used to locate the placenta. You can't cut through the placenta. Lower uterine tone, and you have to lower the uterine tone and maintain the normotension, which is, as I said, Herculean task. As I said, you have to increase the inhalational agents concentration to 2 to 3 MAC. Meanwhile, you have to maintain the blood pressures. The options, as conventionally talked about, is ephedrine, small doses of ephedrine, maybe 2.5 milligrams intermittent boluses. Or you can talk about phenylephrine, 1 to 2 micrograms per kilo boluses, as and when required. There is absolutely no contraindication to use phenylephrine, though the classic teaching says that ephedrine is the gold standard and phenylephrine should not be. But there are a lot of reports which say that phenylephrine is perfectly safe or as safe as the ephedrine when it comes to managing the hypotension in obstetric patients. The fetal part is exteriorized. First, the hand is taken out and you apply the pulse oximeter probe on that, and then wrap the hand around, otherwise you won't get the actual readings because of the bright light or top lights focusing on the operative field. It has to be wrapped adequately. And once the fetus is extracted, you have to consider hypothermia. It's a huge challenge again in the baby. These are the surgeries done through hysterotomy and mid-gestation. Again, the anesthetic challenge is following the uterine closure, you activate the epidural anesthesia, as I said, to reduce the inhalational agents, bring it down to acceptable levels, maybe 0.5 MAC to maximum 1 MAC is all you require. And you start tocolysis with the magnesium sulfate. It's again massive doses, 6 grams IV and infusion at 2 to 3 grams per hour. Preferably magnesium sulfate is continued for at least 2 to 3 days. If not, continue for at least 48 hours. You reverse the patient, extubate and shift to the high dependency unit because patient has to be nursed and patient will be on tocolytics. Hemodynamic monitoring has to be continued for at least another 2 days. Exit operations, ex utero intrapartum treatment procedures. It's an intervention that occurs at the time of delivery. I have 4.5 minutes left, is it?
Yeah.
Okay. It's primarily used in cases where baby's airway requires surgical intervention, cervical teratomas or tracheal anomalies or laryngeal webs. The baby, the fetus, when it comes out, it may not survive, or it may not give you enough time to manipulate or manage the airway if you don't intervene before the uterine, the placental blood supply is cut off. It starts as a routine LSCS but under general anesthesia. Head of the baby is delivered, but the placenta is still in situ. Therefore, though the head is outside the uterus, the placental circulation still continues. Therefore, the source of oxygenation to the baby is not cut off. And you either directly do a scopy and intubate, or if you can't visualize the cords, you can always do a bronchoscopy and intubate. Either you do it yourself under strict asepsis, or you ask your surgical colleague, to either the fetal surgeon or the pediatric surgeon, to do that. After that, cord is cut and the baby is delivered. And if the baby requires further surgical attention immediately, it's mandatory that you keep 2 ORs ready at the same temperatures and same facilities for the surgery to carry on the fetus in the next OR. What are the maternal risks? The tocolytic therapy, magnesium sulfate, when you use this much, can cause pulmonary edema. As such, they can leak more because of the changes in the colloid osmotic pressure and the hydrostatic pressures. Subsequent delivery by LSCS, intraoperative blood loss can be a huge problem because of maximally relaxed uterus. Unless the staples are placed properly, patient can bleed, and managing it becomes a little difficult. Amniotic fluid leak is a problem. Wound infection and intrauterine infection if asepsis is not handled properly. The fetal risks could be prematurity, intrauterine infections, fetal vascular embolic events, premature closure of ductus arteriosus, and CNS injuries if you don't take care of the oxygenation intraoperatively. The fetal organ system is immature, and fetal cardiac output is sensitive to heart rate changes. We all are aware of that. And because of the high vagal tone and low baroreceptor sensitivity, the babies respond to stress with precipitous bradycardia, which doesn't augur well for the cardiac output. As I said in the beginning, fetal circulating volume is low. It could be as low as 50 to 70 ml. Therefore, hypovolemia can be disastrous. And maternal anesthesia as such depresses the myocardium of the fetus and the circulation. Fetus tends to lose heat much easily. Hypothermia is an issue. Immature coagulation system can predispose to bleeding and difficulty in hemostasis, and there can be more bleeding and more hypovolemia. Maternal anesthesia usually reduces the placental blood flow, and this reduces the amount of oxygen delivered. And normal fetal oxygen saturation is about 60 to 70%, and therefore anything above 40% is acceptable to us. And the intraoperative fetal distress is manifest by brady and decreased fetal oxygen saturation and reduced stroke output. And during prolonged surgery, therefore, it's suggested that you push in O-negative packed cells. What are the fetal monitorings you are supposed to do? It's better to have an echocardiography running and a pulse oximeter as soon as the upper limb is extracted out. Few lines on postoperative care. It's high risk of preterm labor. You have to be prepared for that. Magnesium sulfate is the tocolytic of choice, and maternal analgesia is important. Therefore, you put in lumbar epidurals. To avoid, basically the pain itself can precipitate preterm labor and fetal distress. Epidural analgesia has to be continued for a few days, at least 1 to 2 days. What is fetal pain? I will just take 2 more minutes. Pain by definition is a subjective phenomenon, and it is not possible to assess the fetal pain directly, but you can always measure the fetal cortisol, beta endorphins, and you will know that the fetus also has pain. And that is established by a exaggerated pain response in an 8-week-old infant when the baby had to come back for surgery. His response indicated that as a fetus he had gone through the pain. And this also can precipitate preterm labor. Fetal surgery is a roller coaster ride for the fetus, and it's our endeavor to ensure that the fetus comes through it smiling and unharmed. This is Michael Skinner. It's a rare photograph of Michael Skinner with Michael Harrison, the doctor who did the surgery. And he is the first baby in the world to survive successful fetal surgery, and Michael Harrison is the surgeon. It's unique because fetal intervention involves 2 or 3 patients simultaneously, the mother and the fetus or multiple fetuses. The mother receives no direct benefit from the intervention itself other than psychological assurance of fetal well-being after a successful procedure. The mother is a bystander while the fetus or fetuses are active recipients of fetal therapy. Thank you so much.